Welcome to Duke Spine Institute live stream spine surgery, January 30, 2025. I'm Dr. Duke Majan, CEO and founder. This patient comes from Canada. He has horrible neck pain for 10 years. We've just finished doing his cervical facet, Duke plasma rhizotomy, to kill the pain nerves in the back of his neck, causing pain. We're now going to fix one disc that is herniated, causing his symptoms. That is number 5-6. Everybody agree, 5-6? Yes, left approach, we're on the left side. Okay, we're ready to get started. Step one, our patient is asleep under general anesthesia. I'm going to displace the tracheoesophagus with my 2 fingers. I'm going to feel the front of his spine. I can feel it right there. I'm going to place my needle because I'm going to use a needle to get to the disc. And I'm going to check where I am. 2, 3, 4, 5, 6. Everyone agree, 5, 6. I'm going to reposition my needle a little bit up north. Shot. Better. AP, 2, 3, 4, 5, 6. So I'm happy on the lateral view. I want to check the front. Back to you. Make sure I'm in the middle. Shot. I'm in the middle. Okay, let's go lateral. If you have questions during surgery, ask them by typing them in your dialog box. We are streaming on YouTube, Facebook,
LinkedIn,
X.
Twitter, X, and Instagram.
Perfect. AP? Yeah. All right, needle is at the front of the disc. Before I plunge, I want to make sure I'm in the middle. Shot. 2, 3, 4, 5, 6. That's it. We're in the middle. Perfect. He does have a little scoliosis. You could see that on the lateral view before I started, and it's centered at 5-6. Why? Because number 5-6 is damaged. Shot. Okay, we're in 5-6. We're ready to go. We're going to do a discogram. 2, 3, 4, 5, 6. If you notice, I count like 5 different times. Why? Because you want to make sure as a surgeon you are operating on the right level. Shot. And it's very important you don't ever operate on the wrong disc. Shot. All right, look at that tear. That is massive. Jordan, show us the tear. All that black, that giant black leaking out the back of the disc. Look at the herniation, folks. Put the arrow on the herniation. Right there. You guys see that bump sticking out? That is his herniation. That's where his symptoms are coming from. We're going to go remove that with the laser. All right. If you have questions, feel free to ask. Otherwise, Henry, start us out with the 30 causes of neck pain. The 30 most common causes of neck pain. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3. Next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Welcome back. You can see from our video, you can go lateral with the fluoro, but keep your picture. You can see from our animation that there are 30 things that cause neck pain, including 14 facet joints and 6 discs. Now just take a look at this front-back view. First of all, notice the tip of the dilator is in the middle of the spine, right where we want it, at the front of the disc, right? The guide wire runs across to the right foramen. That's where most of his pain is, on the right side. Look how big the tear is on the right side. See the dye, the black dye? It's big. Look at the left side, not as big. But there are tears on both sides. We're going to fix both. All right, so shot. Next, I'm going to advance the dilator through the disc. I'm going to take the guide wire out. Shot. Now, the beauty of this Duke laser disc repair surgery you're watching, it's revolutionary, state-of-the-art surgery for any kind of disc problem, like a herniated disc, bulging disc, ruptured disc in the neck or back and thoracic. So why do this over a fusion or artificial disc or a laminectomy or discectomy? Because it's less invasive, it's safer, and it's more effective, and it's more durable. Look at the size of that herniation. It did not look that bad on the MRI, so clearly it's gotten worse. It is big. It's a lot bigger than I saw on the MRI. All right, we are inside the herniation. Folks, we have literally lost 1 drop of blood. There it is, 1 drop of blood, the whole surgery. That's another reason why you want to do this surgery, Duke laser disc repair at Duke Spine Institute, rather than open surgery. We've had 0 complications to date. Let me go ahead and advance. I'm going to slide the tube. This is a 4mm tube, sliding it down along the shaft of the dilator. This is arthroscopic spine surgery. It's not really done anywhere else in the United States, unfortunately. I've been teaching it for years. But surgeons like to do procedures that give them more money than this surgery. This surgery does not pay the surgeon very well, so they're motivated to do fusions and artificial discs instead. I've been teaching this surgery now for years. I've even taught it at the American Association of Neurological Surgeons meeting, at the Congress of Neurological Surgeons, at Becker's Spine Review, at the Southern Neurosurgical Society, at the Florida Neurosurgical Society, and at the Global Spine Conference in Hong Kong. I've taught this procedure all over the world. Oh yeah, Los Angeles, at the brain. Okay, just so you know, the dilator is getting shoved back up the tube. See that? Shot? I'm putting it in and it's popping back up. Why? Because there's so much pressure inside this disc. Look at that. That's crazy. This disc has so much inflammation happening right now that it's literally shoving this thing back out. Okay, we've seen this before. It's an impressive finding, but that's because the hydrostatic pressure in the disc is so high, it's literally shoving the dilator back out. That happens with inflammation. That's the only reason why that happens. So I've got to keep taking my tube out and putting the dilator back in. If I don't put the dilator back in, then I'm going to be biopsying the whole disc, and I don't want to biopsy. I want to take the herniation out only. Shot? Almost there. Any questions, Shot?
Yes, we have a few questions. This next first 2 are coming from Pawn Lust on YouTube.
All right, we're at the back of the disc with the tube. Jordan, show us the tube is at the back of the disc. So now I've got a channel that I can see the herniation and remove it with a laser. All right, I'll take the questions.
First question from Pawn Lust asking, wow, how fresh is that?
Yeah, Pawn Lust, this is a fresh herniation because it's under so much pressure. You don't see that with the old dried out, degenerated disc. You see it with the more acute herniated disc. So it's fresh. It's like now. It's happening today. This is an active war zone, basically. This is not a burnout war zone. This is an active war zone. We're not talking about guerrilla warfare here. We're talking about full-on, military activity maximum. With the old degenerated disc, you're talking about burned out areas that saw action many years ago, and there's a little bit of inflammation left. That's kind of the guerrilla fighting that's happening in the burnout buildings. I'm having trouble seeing because that light's right in my eye. Thanks. Great question, though. This is a fresh herniation. That's why it's so blue and soft. All right, let's keep the questions coming.
Next question from Pon Lust once more on YouTube asking, I don't have a problem with C2-3, but I've heard it's especially difficult to even do PRP injections around there. Is it a lot more challenging for this procedure too?
Great question. So fixing a disc at C2-3 is very difficult. It's probably the hardest disc to fix in the neck if you need to. Thank God, only about 1 in 10,000 patients need a C2-3 disc fixed. So the vast majority are C5-6, C6-7, C4-5, C3-4. But it's less than 1 in 10,000 that need a C2-3. I have only fixed one C2-3 disc in my entire career of 28 years operating as a neurosurgeon. And that was many, many years ago. It's not common at all. Very hard to do though, very hard. And the patient has to have a really long neck and a high jawbone. If they don't have a high jawbone, you're never going to get to C2-3. The good news is you only get a herniation at C2-3 when the jawbone is high. That means that segment is very mobile and susceptible to injury. All right. Great questions so far.
Yes.
Great questions. I've got a little bit of herniation stuck to the side of the laser. You guys see that? That little white stuff? And it's kind of blocking my view. It's somewhat annoying me. I'm going to have to go and take this thing out just to get that off so I could see better. So, oh, it looks like, yeah, it's still there. Hold the tube, please. I'll do that. You just hold the tube. Okay, I don't want that tube coming out. Alrighty then. Well,
We have a few more questions.
I'll take the, well, where are we on the animation?
Oh, we've been back.
Where are we at? I mean, I know we're back, but what animations have we shown?
we've shown only the 30 causes of neck pain.
All right, so before we take any more questions, I really want everybody to understand how it is these herniated discs can cause so much pain and so much symptoms in the neck and the arm, even headaches. It's all due to inflammation happening in the very back of the disc, okay? So Henry, let's show the audience how do herniated discs cause so much symptoms.
Copy that.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963. Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
That's right. Neither is the endoscope. The endoscope is oblique, right? It looks like an egg on it if you look at it, right? It's not round. So the endoscope egg has to fit into the tube egg shape. Does that make sense? So help me keep it pointing towards you. Great. So we're just working here at C5-6. You can see big, look at all these pieces of herniation coming. I've had to float out about 10 of them. This one barely fits out the tube. That is a piece of herniation in the back of the disc, and I'm trying to blast it with a laser to make it smaller so that it floats up and out. Any questions?
Yes, we have a couple questions. Next one coming from Lanu on YouTube.
Hi, Lanu.
Asking,
Sure.
can neck pain cause shoulder pain?
Can neck pain cause shoulder pain? Yes, for sure, but not every kind of shoulder pain, but you can have pain in the shoulder that comes from the neck. Okay? But you cannot have shoulder joint pain or rotator cuff pain from the neck. That doesn't make sense. But neck pain can definitely cause pain to radiate from the neck into the shoulder. It's called cervical brachial pain, CBP, cervico-brachial pain. Okay? Very important. Pain radiating from the neck into the shoulder. Very well-known phenomenon, very common problem. All right, so I'm at the back of the disc, and I'm looking at the posterior longitudinal ligament, and I'm thinking to myself, has this herniation gone through the PLL? Oh, look at that. Big reverse herniation right there. Nice job, Louise. Thank you. Wow, look at that. All right, let me see. Don't push down too much. Okay, just right there. Oh, another piece of herniation right there. Huge, huge herniation. Now just hold the tube, but don't push down. Any other questions?
Yes, this next one is coming from Dr. Shamayu Dutta on YouTube.
Hello, Dr. Shemaya Dota.
Asking, do you do this for sequestered discs too, or reserve it for only contained discs only? Also, I can imagine how much resistance you must be facing to publish the long-term results of your work, but you can share it here nonetheless.
Doctor, I love it. Thank you so much. You are 1,000% correct. Number one, I encounter massive resistance because of the industry that basically sells all the stimulators and metal implants, artificial discs, cages, metal plates, everything that's implantable that makes billions of dollars for big companies. Yes, I am encountering resistance from them, but indirectly through the societies, through journal editors. All the journals are now controlled by implants that are planted there by these companies. They're doctors that only publish what the Boston Scientifics, what the Medtronics and DePuys and Synthes and Nuvasives want published. They don't publish real science or real research. They don't want this technique known because there is no metal, there is no implants that are used. So yes, there's massive resistance in America to adopting surgery that doesn't use implants, right? Surgery that's better for the patient, that doesn't use any metal implants or plastic implants or stimulators, neuromodulators, whatever. Okay, so you're right. I've encountered this resistance for many years. I did publish, thank God, Dr. Jim Osman, who was a professor emeritus neurosurgery, UCLA, and editor-in-chief of the Surgical Neurology International. He believes in this technology. He wants the world to know. He published our paper, and I've published also at scientific meetings. But the truth is people have never adopted this technique because it doesn't pay well. Hospitals don't make money. Doctors don't make money. Implant companies don't make money. The only people that benefit from this surgery are the patients, and I suppose me, because I'm the one doing it. So, unfortunately, you're right. There's tremendous resistance to the adoption of this technology and technique, even though I've been publishing it now for about 15 years. Okay, internationally and nationally. Now, as far as sequestered discs, if the herniation is posterior sequestered behind the PLL, then I can remove it, no problem. But But if it's migrated and sequestered behind the vertebral body, I cannot. It will not work. I do not recommend it for those types of herniations unless the sequestered disc material is very small, unless there's not much of it there. There's not really any compression from the caudally or rostrally migrated piece of herniation. So I don't know if I answered your questions. I hope I did. This is the uncinate process base. You can see it. This would be C6. There's a little bit of osteophytic ridging back here, but the nerve root is right in there underneath this material. So you have to be very careful. There's a little bit of herniation left. There's not going to be much mass effect, but you can see right there is the foramen just underneath this soft tissue. This is both ligament and herniated disc and scar tissue from chronic inflammation and calcification. You see the calcium there is the gold color, but basically the nerve root is going to be just there at the tip of the laser, and I'm going to go look for some more herniation pieces. We've already taken out about 15. All right, great question, doctor. Thank you for joining us. So happy to have you here. I'm going foramen to foramen. We were just over in the right foramen at C5-C6. Now we're heading to the left side. You can see the posterior ligament there, the white color, the fibers, they're intact. I'd like to leave them intact if I can. And we're going basically from, don't push down, one side to the other. I just have a little bit more herniation to remove and we're done. You can see some inflammatory tissue right there, the red stuff right there. That's inflammation. You see that? That's where the pain comes from. It comes from chronic inflammation in the back of the disc within the annular tear, within the wall of the annulus. You see that right there. That is inflammatory tissue. Okay? That's what we're here for. You remove that, you get rid of the pain. This is the foramen over here. There's a little bit of herniation. There's a little bit of foraminal ligament right there. That's extension of the ligamentum flavum into the foramen. The laser is 1/2 millimeter wide, 0.5 millimeter. It's actually 0.45. A little bit of inflammatory tissue there, but the spinal cord is just underneath that. So I'm not going to take any chances to damage the spinal cord or cause a spinal fluid leak. I'm not going to hit that. I'm going to leave it. All right, there's another piece of herniation that was in the foramen. I went back to the other side. So we've now gone across the back of the disc, foramen to foramen, and I don't really see anything more that needs to come out. There's a little bit of tissue, soft tissue in the foramen here, but for the most part, the nerve root is decompressed, the spinal cord is decompressed. I'm very happy with these results, and we're done. Dr. B, we're done. I will take more questions, but I'll come and answer them face to face, so type up your questions. And in the meantime, Henry is going to show you the second most common cause of neck pain, which is the facet joints, if we haven't already done that, and how we fix it here at Duke Spine. One more piece of herniation right there. You guys said that?
Yes, we did.
Other than that, things are looking pretty good. Another piece. But we should be maybe one more right here. That's why we always look. These are all fragments of disc material, herniated disc. Nucleus pulposus. Let's flip it one more time. We have irrigation or no? Yes. All right, I don't want to, I'm just about done. Go ahead and type your questions and I'll come answer them for you face to face. Our next case is going to be the lower back, a patient who travels from Canada with lower back pain. We're done. And he's had pain for many years. He has 3 disc herniations and he has radiculopathy. His biggest problem is not back pain, it's more weakness in his legs. We call it neurogenic claudication with standing and walking. His legs get weak and numb on both sides. So we're going to go and decompress the nerve roots. That's our last case for the day, right? Yeah. All right, so Henry, go ahead and show our audience facet joint pain while we take the tube out and put on the bandage. Okay, you see how facet joints cause pain. It's injury to the joint, which results in inflammation, and that inflammation causes pain. We'll show you in a moment how we treat it at Duke Spine for a permanent cure. But here is the incision. We have lost 1 drop of blood the whole surgery. This is a 5 millimeter incision, 5 millimeters. So he's going to go home in an hour. As soon as he recovers from general anesthesia, he'll go home, back to his hotel. He'll come in for a quick checkup in the morning and then go back to Canada, where he lives, from Florida. All right, I'll come answer your questions. In the meantime, Henry is going to share with you how we fix facet joint pain in the neck. And good morning, I'm Dr. Duke Majan at the Duke Spine Institute. I'm here with my patient who traveled to Duke Spine Institute with a couple of problems. She had neck pain from a herniated disc and facet joints, and we fixed both yesterday. She's here less than 24 hours after her surgery. She went home, back to her hotel with her family afterwards, and she came back in for a quick checkup. You can see the incision for her surgery is 4 millimeters. It's tiny. How do you feel today?
I feel good. A little sore from surgery, but that's normal. I'm so much better. I could just feel that I've been fixed, and that was not gonna happen without you.
Well, how did you hurt your neck?
I got into a motorcycle accident back in October, and it flew off the bike.
And you've been suffering since then?
Yeah.
Why did you decide to come to Duke Spine Institute?
Do you have enough time?
Sure.
I came here because I was told that I had to have this really invasive surgery. They wanted to do a discectomy.
And fusion.
Yeah, and I was very scared. I was very scared, especially after reading what could happen, the risks. It was just too much, and actually kind of scary, because when I looked into the doctor, he actually had a lawsuit against him, which the people who suggested him to me were not aware of. So I kept doing my research. I thought, well, maybe I'll just figure out how to do some exercises to help my herniated disc, which, yeah, now that I know what I know, that's not gonna help your herniated disc. Nothing is gonna put that stuff back in your disc.
That's right.
So I did 6 months of physical therapy. That was unsuccessful. I still had pain in my neck, and it was really bad. I would turn my head anyway, and I would always feel the pain right here, feel the pain in my C6. I couldn't do the things I normally did. So when I did my research, trying to look for exercises I could do to help my disc, he popped up on my feed and said, "Do you have a herniated disc? I can fix you." And the more research I did, I was just so thrilled, because nobody has his impeccable record. No one. That's why I went to him. He knows what he's doing. He is crazy confident. His staff is amazing. They're so kind. They're so attentive. The lady that did my IV was so gentle. She did it, and I was like, "You're done already?" The people here are amazing. This doctor knows what he's doing. God has his hands in his hands.
Amen. We are so thrilled that you were able to get your neck fixed here and avoid that metal plate and the fusion and the discectomy, which is totally unnecessary, by the way. I'm trying to help people understand the truth. There's no need for ACDF fusions anymore for degenerative disc conditions. We can fix it with the Duke laser disc repair and the Duke plasma rhizotomy. You can see in your video here, we went into your disc, we used the laser. We actually pulled out several big chunks of herniation. I don't know if you watched your surgery, but you could see them coming out from the back of the disc. I cleaned the back of your disc beautifully, got the foramen opened up. There was nothing in there when I was done. Now your disc is going to heal naturally without any problems. Is there anything you want to tell the rest of the world out there that you haven't already said?
If you're in any kind of back pain, any kind of neck pain, he's the only option, because he knows what he's doing. Really, he can help you. He's helped people get out of wheelchairs. He's helped people be able to ride horses again. I mean, I'm gonna be able to go back on a jet ski. I'm gonna be able to go back to my life. Obviously not right now after my healing time, but I wasn't gonna be able to have that happen before. And I'm an adventurous person. So if you're an adventurous person, if you're in pain, if you want your life back, you need to come here. You need to come here. You will never regret it. You will never look back. I promise you with all of my heart. He's the one you need to be with.
Well, congratulations on taking the faith and getting it fixed.
Thank you. Thank you so much.
You're welcome.
You've made me so happy.
You have a beautiful family. Please tell your husband I said hi. He's a very smart man.
Absolutely.
And I'm very happy you're doing well.
Thank you so much.
You're welcome. All right, take care.
You too.
Let's get you out of here. All right, wasn't that fantastic? I'm Dr. Duke Machen. Good to see you again. It's been a while since I've done a face-to-face with you after surgery, but we've been busy today fixing people's neck pain. And neck pain is not as common as back pain. Lower back pain is by far more common. I would say out of every 4 patients we see, 75% have lower back pain, 25% have neck pain, and maybe 1% have thoracic pain. So the numbers are skewed towards lower back pain being more common. But when people do have neck pain, it is almost always coming from a disc problem or a facet joint problem. And just to show you what I'm talking about, if you take a look at our spines, okay, it's made up of joints and bones, all right? People say bones and joints. The spine is actually more important than bones is the joints, all right? And there's 2 types of joints in the spine. You have disc and you have facet, F-A-C-E-T. Now for every disc, there's 2 facets, all right? So you kind of get the idea, right? Now in the neck, let's just take the cervical spine here. Forget about the metal plate, but you have bones stacked on top of each other, but to have movement, you need to have joints between the bones. So the big joint in the front is the disc, the small joints in the back are the facet joints. You see that?
Yeah.
So for this patient we started with the last stream, we did his facet joint rhizotomy, and to get rid of the pain from the facet joints, you must target a small nerve. This is the front. The nerve comes out of this hole called the foramen. It wraps around right here on this bone, and it goes up to this joint, down to this joint. It's called the medial branch of the dorsal ramus. And I targeted it right there and cut them. And that's called the Duke plasma rhizotomy. Again, we have a patent on it in the United States. I'm the inventor of this technique. First time in the world. It is the only treatment in the world that cures facet pain without doing fusion, basically. You don't want fusion. It's much worse. So that's what we did first, and then we went in and repaired the disc at C5-C6, and honestly, it was a lot worse than I expected based on the MRI. The MRI showed there was a tear and a herniation. I knew that was the problem, but it was not as bad as it was when we got in there. When we got in there, you saw how big the herniation was with the dye going around it, how big the tear was. So it was much worse than expected based on the MRI. You cannot use an MRI to determine where your pain's coming from. MRIs do not tell people where pain comes from. You do not use an MRI to make a diagnosis of where pain comes from. You use the Duke spine exam, and again, that's another patented thing that we do. It's a combination of diagnostic imaging, physical exam, and history from the patient that you combine the 3 to make the diagnosis. And that's what we do at Duke Spine Institute. I do that through my free MRI reviews on our website. You can get one done, you or somebody you know with back or neck pain. It's free. We don't charge. All you got to do is give us a little bit of information and some pictures, and then we do the free MRI review. I do it with you personally. We usually give you 10 to 15 minutes. And at the end of that time, we want a diagnosis, what's causing your symptoms, and a treatment plan. We also can answer some questions. All right, so 2 neck cases. We got a back case coming up. The guy has back pain with basically weakness, numbness, and pain in his legs from pinched nerves. We're going to do that next. But right now, we're going to take some questions.
These first 2 questions are coming from Lanu on YouTube. First question they asked is, why does it take up to 12 months to heal an annular ball?
Lanu's asking a great question. Dr. Duke, you talk about how you go in and clean out the junk that's stuck in the wall of the disc. Why does it take 12 months for the disc wall to heal after you clean it, debride it? It's called the debridement, so we'll use the right terminology. Well, the reason I think is because the annulus wall of the disc does not have much blood supply. The annulus is very well known. You talk to any doctor, they'll tell you the disc does not have a blood supply, but it does. The outer part of the wall has a blood supply, the inner half of the wall does not. So the whole wall has to heal. So it heals very slowly, mostly through what's called diffusion of nutrients, and diffusion healing takes a long time. Tissues that don't have a good blood supply heal very slowly. So that's why.
Next question from Lana, once more on YouTube, asking, can MRIs show the annular wall if that is healed or if healed?
So Lana is asking, can an MRI show if the annular wall is healed? The answer is no. In 2025, current technology with MRIs cannot show if an annular wall is healed.
And then lastly from Faisal on Facebook asking, Doctor, if I have a disc replacement surgery that 2 years down the line is causing mechanical pain, what treatment would you recommend and offer in your facility? Thank you.
Faisal, you always have great questions.
Yeah.
So does Lanu. So Faisal's question is interesting, and I'm smiling because it's a little bit of a tricky question and answer. But let me see if I can help explain it to you guys. Give me 1 second. I need to find the right toys. Where's my artificial disc?
Is that not it? In front of you?
No,
That's not it? Oh.
that's a fusion. There's one that moves, an artificial disc that moves. You know what? It may be in my office. So
yeah, if not, I'll have me and Luis will look for them.
yeah, I think it's in the office somewhere. I thought it was here. Maybe somebody stole it. But anyway, let's just take this segment here. Okay, let's pretend this is your artificial disc right there. So your artificial disc is moving, right? Your bones are moving at the disc. What else is moving? Your facet joints are moving. So the most common reason artificial disc surgery fails is because people have pain in the facet joint that was unrecognized by the surgeon before they put the artificial disc in. Facet joint arthropathy or pain is a contraindication. You're not supposed to put artificial discs in when the patient has that. These surgeons don't care anymore. They just want the money. They want the business. So they'll stick an artificial disc in anybody, even if you have facet pain. They shouldn't. You're not supposed to. Anyway, even if you did get an artificial disc and you have facet pain, come to Duke Spine. We'll treat your facet pain and we'll permanently cure it. The second possibility, besides facet joint pain behind the artificial disc, is adjacent segment disease. Now you have something else next to the artificial disc causing your pain. Unfortunately, we found that patients who get artificial discs have the same incidence or rate of adjacent segment disease as the patients who have fusions. So artificial discs do not protect you from having the next disc above or below or facet above or below start causing symptoms.
That is it for questions.
Well, guys and gals, I'm disappointed. So few questions.
We just got another one. This is from Pawn Lust on YouTube.
All right, Pawn Lust, hi.
Asking, have you tried putting fibrin or methylene blue into the tears and herniations? I know intradiscal methylene blue has some decent pain relief results. Not sure why.
So great question. Thank you for asking. Yes, we've tried both fibrin, methylene blue. They don't work, unfortunately. Our company, just to take a step back and explain this, we're not interested in doing treatments that don't work. We only want treatments that really do work. So what does that mean? What does work mean? What does Dr. Duke mean when he says treatments that work? I'm talking about a treatment that, number one, must cure the pain with one treatment and it's gone permanently the rest of your life. If you're going to live 30 years, the pain will be gone for 30 years. You're going to live 50 years, your pain's gone for 50 years. If you're going to live 80 years, the pain is gone for 80 years. How do you do that? You do that with the treatments that we do every day. The Duke plasma rhizotomy for facet pain, the Duke plasma rhizotomy for sacroiliac joint pain, the Duke piriformis release for piriformis muscle pain, the Duke laser disc repair for discogenic pain, and then kyphoplasty for fracture pain, okay? And then for C1, C2 pain in the neck, we do a C1, C2 fusion. And for occipital neuralgia, we do an occipital Duke plasma rhizotomy, occipital nerve Duke plasma rhizotomy. So our focus is on procedures that work. Work means they cure your pain, not make it better for a few hours, but cure the source of the pain. The second thing that's important is we want no complications, zero. No complications for the patient. We don't want the patient to have a new problem that they didn't have before. We don't want our patients paralyzed. We don't want our patients with spinal fluid leaks, infection, nerve damage, none of those problems. We want zero. So we want treatments that have almost zero or zero complications. That's our goal. Our procedures, the Duke plasma rhizotomy, the Duke laser disc repair, these are complication-free surgeries. We don't have complications from them. So right there, when you look at just postoperative complications or intraoperative complications, Duke laser disc repair, Duke plasma rhizotomy, zero complications. Other treatments have hundreds or thousands of complications or more. So complications are important. The next criteria is recovery. What surgery has the fastest recovery? What spine surgery has the fastest recovery? Duke laser disc repair and Duke plasma rhizotomy have the fastest recovery. Now, rhizotomy, RFA, has a fast recovery too, just like Duke plasma rhizotomy, but it doesn't work or it doesn't last. So that's why it's not a good procedure, okay? There are other minimally invasive spine treatments that have fast recoveries, but they don't work, like disc seal, doesn't work, okay? Or basovertebral nerve ablation, all right? That doesn't work, but it has a fast recovery. So we're not interested in surgeries or treatments for patients that don't work, even if they have a fast recovery. We want fast recovery and works. Finally, there's postoperative pain from the procedure. Our procedures have very little postoperative pain, minimal. Our patients don't take narcotic opioids after surgery for the surgery pain. They only take a muscle relaxer, anti-inflammatory, that's it. Other types of spine surgery, patients need opioids, painkillers, Percocet, oxycodones. Those are dangerous and addicting drugs. So when you look at the big picture, our treatments at Duke Spine are focused on curative with one treatment, fast recovery, no complications, immediate return to normal life, and no need for narcotics. That's why we do what we do.
And we do. From that, we got a lot more questions. Next one's coming from Gary on YouTube,
All
asking,
right.
how do you repair adjacent disc disease? Same way with laser repair?
Hi, Gary. Thank you for asking. Yes. So let's just take, I'm grabbing a fusion model. All right. So let's take this one right here. We've got a back. This person had screws put in. They're getting an instrumentation and fusion at L5-S1. That's called L5-S1. L5 is the bottom bone in the spine. S1 is the first bone in the tailbone, with really 5 bones fused together. So S1 is the top. L5-S1 fusion. Adjacent segment disease is where you get symptoms that develop at the next disc above, L4-5, or the facets above, L4-5, or below at the SI joints. That's adjacent segment disease, okay? So pain from the SI joints, pain from the disc, pain from the facets. So the treatment depends on the source of pain. If it's SI joints, it's Duke plasma rhizotomy. If it's facets, it's Duke plasma rhizotomy. And if it's the disc, it's Duke laser disc repair.
Next question coming from Faisal, once more on Facebook, asking...
Should I move to the left?
Yeah, a little bit. You're good.
Is that better?
Yeah, works much better, yeah. I was told that an artificial disc turns into a weird kind of fusion. Have you seen that?
Yeah, artificial discs do tend to fuse. So what happens, it's well known, it's been known since the very early days of artificial discs. When the surgeon goes into your disc to put an artificial disc in, they're going through the front. They're going through your belly, in your lower back, that is. In your neck, they go through the front as well. but they're going through your belly. They're taking this whole disc out. Now, if they start accidentally taking bone spurs out, or even on purpose, start drilling and removing bone spurs, what's going to happen is now you've decorticated the bones above and below by removing bone spurs. Now you have a surface on each vertebrae that wants to fuse. So you're going to get a fusion now because you've decorticated the bones. Decortication means you're removing the outer surface of the bone, exposing the inner bone called the cancellous bone, or bone marrow is another other name for it. And once you've exposed bone marrow on two bones next to each other, they want to fuse together. That's what's going to happen.
And then next question coming from Dr. Shamayu Dutta, once more on YouTube.
Hello, Dr. Shamayu Dodo.
Dutta, D-U-T-T-A.
Duda.
Dutta.
I wonder what kind of name that is.
It's a very interesting name. If you would like to answer, not a problem.
We'd love to know where you're from, Dr. Shamayu Duda.
Till then, he asks, have you done post-op MRI scans to see if the cervical herniations ablated/removed? If so, how often does it not show a difference, pseudodisc, although the patient's symptoms may be better/resolved?
Great question. So you're asking a great philosophical question. Should you get an MRI to look? The answer is no. You don't need an MRI, because there's one thing more sensitive than an MRI, and that is the endoscope, looking directly at the back of the disc where the herniation is. That's what we do. You can actually see everything clearly with the endoscope, as you just saw. You don't need an MRI. Endoscopes have a resolution, the endoscopes that we use that are high definition endoscopes have a resolution of 1/20th of a millimeter. So take a millimeter divided by 20, 1/20th of a millimeter. That's the resolution, the visual resolution of an endoscope at the back of the disc. The resolution of an MRI, a standard MRI, is about 3 millimeters. And MRIs use volume averaging, which means you're not even seeing what you're seeing. That's not a real picture you're looking at. It's actually an average of basically energy released by different tissues that's added together in a computer algorithm and spits out an average picture. All right. So if you were to take a picture of my nose and you were to get it here, and then you get another picture here, it would give you an average nose that would be somewhere between the two. All right. That's not my real nose. My real nose is what you see three-dimensionally. I can see three-dimensionally with much greater accuracy with the endoscope. We don't need an MRI. And second of all, what's more important anyway, the patient's symptoms and exam findings or an MRI finding. MRIs never tell us what's wrong. Okay, you've seen probably thousands, I don't know what kind of doctor you are, but thousands of herniations that are asymptomatic. And they could even be big herniations. Who cares what the MRI shows? What matters is what the patient is experiencing. So if the patient has their motor exam go from weak to normal after surgery, sensory loss to sensory gain. So if you have restoration of neurological function, you have elimination of pain, and who cares what the MRI shows? The patient is now cured, symptom-free. That's what matters. Yeah. So the whole concept of using diagnostic imaging as a surrogate marker for success in spine surgery is old-fashioned, outdated, and needs to be replaced. Unfortunately, many doctors still believe you should get diagnostic imaging, and they judge the success of their treatment based on the imaging rather than the patient-reported outcome. What matters to me is patient-reported results, patient happiness, patient success. I don't care about diagnostic imaging success. Remember, we're operating in very small spaces with very small changes. They're very strategic.
Next question. Got a lot. Next question coming from, from Faisal once more on Facebook, asking, what I also want to know is, can your body reject the artificial disc, which cause mechanical pain with alpha set pain at that and adjacent segment disease? Thank you.
Yeah. Faisal, great question. Can your body reject the artificial disc? Yes, it can. There is always some rejection of any implant in the body, whether it's plastic, metal, doesn't matter. there's always going to be some rejection. That rejection is not immunological rejection. It is basically foreign body rejection. It's mediated by the inflammatory system, and you get what are called giant cells response to the foreign body. So could your pain be coming from the artificial disc? Yes. It's just very unlikely that it is. Very unlikely. Facet pain, adjacent segment pain, far more common.
Next question coming from Professor on YouTube, asking if you were having problems with a herniated disc, CT or L, can you recommend someone in New York City or the surrounding area that you can trust?
Yeah. Professor on YouTube?
Yes, Professor on YouTube.
Professor on YouTube, thank you for asking. I cannot recommend anybody in New York. We have people from New York who travel here, people from Turkey and from Greece and from Asia, Indonesia, Hong Kong, all over the world. They travel to Duke Spine for our treatments. There's a reason, because doctors are not performing these treatments elsewhere. Doctors are unfortunately performing the wrong treatments on patients, especially in New York. We have a lot of patients from New York. I'm not going to badmouth any doctor in New York by any means. I'm just saying that the physicians that treat spine issues that are degenerative in New York are unfortunately providing treatments that are arcane, extremely outdated, and unfortunately rarely result in a benefit to the patient. So my advice to you is don't make the mistake of going somewhere else for treatment. Come to the very best, get the best. Okay? I just had, whenever I have surgery for myself, I'm a consumer as well, I'm a patient. I prioritize quality of care over anything else. Some people prioritize convenience of treatment, like is it close by, is it easy to get in. Some patients prioritize the niceness of their doctor. Oh, my doctor's so nice. Yes, I have a damaged nerve from the surgery and a spinal fluid leak, but he's so nice. Well, you know, in the end, he can be nice, but you're living with that complication from surgery for the rest of your life. You're in a wheelchair because your doctor was incompetent. All right? You want my advice? Come to Duke Spine. Don't fuck around. Until we have a Duke Spine Institute in New York, I would strongly recommend you at least do the free MRI review. You don't even have to leave New York for it. Just hop online. You get 15 minutes with me, and I will tell you what's wrong and what needs to be done to fix it, as long as it's something that I treat, which is, you know, degenerative spine issues typically. Just go to our website, free MRI review. Just fill it out. It takes 10 minutes. Send us your images. Get a free consult. I don't charge you. I spend my time 2 days a week just talking to people for free. It's okay. And then decide what you want to do. If your problem may not even require surgery. So my advice to you is do the free MRI review. It's available to anybody in the world. We don't discriminate. Doesn't matter what country you come from. Doesn't matter anything. Your financial ability to pay or come here. We do your MRI review for free. As long as you fill out the form, get us the images, I'll schedule you and I'll tell you what's wrong. So yeah, I wouldn't go to New York if I were you.
Next question comes from Mike Jones on YouTube, asking if I've already broken my neck, had a fusion, and still have bad and neck and bad back pain from epilepsy, would this possibly work?
Yeah. Hi, Mr. Jones, Dr. Duke here. Thank you for sharing your story. We can definitely help you. If you're having pain, it doesn't matter who you are, what your background is, what surgery you've had. If you've got neck pain or back pain, Duke Spine Institute can fix it. There's not a single type of neck and back pain we can't fix. Now, we don't treat tuberculosis of the spine. We don't really treat cancer of the spine, like metastatic cancer. But for that, you're going to need radiation, chemotherapy, possibly surgery, reconstructive. I don't do that anymore. I used to do it. I don't do it anymore. I don't want to do it. It really requires a specialty care hospital like in New York City, hospital for special surgery. But that's for cancer. That's for very complex, destructive type lesions. But for regular back pain, even after a fusion, epilepsy, no problem. We can help you. Our procedures are the safest and the best for treating pain in the world.
Next question from Pawn Lust once more on YouTube asking, I would like a long-term solution too. How can there not be complications though? I have an epidural and no complications, but I've read that some people do get dura tears or hematomas.
Well, Pawn Lust,
Pawn Lust. Yes.
P-A-W-N?
P-A-W-N. Yeah.
Pawn Lust, thank you for being so active on our channel. Pawn Lust is asking a great question. I think I understand your question, Pawn Lust. How could there be no complications with our treatments? Well, I mean, I'm not trying to brag, but I'm a good surgeon, a very good surgeon. Most people don't know this, but I graduated #1 in my medical school class at USC in Los Angeles. I'm valedictorian. I was the #1 draft pick in neurosurgery residency the year I applied in 1996-97. I was literally the top pick for the entire country because of my background, my training, my knowledge and experience. So I got to go to the #1 neurosurgery training program in the country, in the United States. That was at University of Florida in Gainesville. I trained under Dr. Albert Roten, Art Day, Bill Friedman, Richard Fessler. These are giants in neurosurgery at the time. They were the best in their respective fields. And that's why the program was so good, because these doctors made it good. So I trained directly with them, Jeff Hann. So I have been trained very well. I come from the top training program. We don't make mistakes that most other doctors make. Now, could I? Sure, I'm human. I can make a mistake. But to me, it's important that I don't hurt my patients. And I have developed techniques over the years, very careful techniques, to be very careful not to hurt the patients. I'm aware that surgeons can hurt patients and have complications. So what I do is I pay attention the whole case. I assess constantly throughout the case, what am I doing? Does this have potential for harm? Does this have potential for complication? And I evaluate what I'm doing ongoing, constantly, nonstop. Even though I'm talking to you guys and I'm operating, I'm actually thinking, all right, here's an area I got to be careful. I might hit a blood vessel, might hit a nerve. I need to be right here, right there. It basically just really good surgical technique and good anesthesia. And that's why we don't have complications. Plus, we're not doing highly invasive surgery. We're doing minimally invasive treatment. So when you combine the lack of bleeding, the lack of postoperative pain, the quick recovery, the minimally invasive nature of the surgeries, the experience that I have doing them, 2,500 of these surgeries, plus thousands of open surgeries, it's really a winning combination. And you're right, it's unusual that there would be no complications, but there aren't. So that's the answer. I don't know what else to tell you. I guess I could go out and get a complication so we can say that I had one, but I don't feel the need to do that. I don't think it's right for the patient.
Next question coming from Faisal, once more on Facebook, asking, Doctor, how far are the discs in the neck? How deep are the discs? Thank you.
Yeah, Faisal, great question. The question Faisal has is this. Obviously, you guys are watching me do surgery, and can you see my neck?
Yeah.
On the camera?
Mm-hmm.
All right. So our patients are laying like this, looking up at the sky. You guys are looking down at the neck. I'm taking my fingers, putting it right here, and pushing down and touching the spine, okay? By doing that, I'm spreading the tissues apart, creating a small path between the skin and the spine. How deep is the spine? It really depends on the patient. Some spines are more superficial. They're close to here, the front, the skin. Some spines are really deep. Trust me, I hate the deep spines, but you know, I don't, turn patients away because they have a deep spine and a thick neck. I do try. You never know if you can get to the spine until you get the patient in the operating room. You position them straight up and down. We call it spine. 2, muscle relaxation. We put a little traction on the arms, pull the shoulders down, a little inline traction from the anesthesiologist on the head, slight extension with a pillow. So you bring the spine as far forward as possible. That brings the number 5-6 as close to the surface as possible anteriorly. So that's what we do. We really, we've thought of every little detail over the years. We've perfected the surgeries here at Duke Spine Institute. That's why you don't want to go anywhere else. You want to come here because we care and we take tremendous pride in our great record of surgery.
This next one is a comment coming from Dr. Shamayu saying that he was from Kolkata in India.
Kolkata, India. Okay, very good.
Yeah, it's 1 a.m. there. Recently used your technique to do a cervical biopsy and debridement for spondylodiscitis. So, thank you.
Great job, Dr. Shamayo.
Shamayu do that. Yeah.
So happy to hear you've used that technique. I would love to know what endoscopic system you use. I use the Wolf. The system I use is the old Wolf system. I don't like the new one. It's too big. And I have an old principle of if it isn't broken, don't fix it. I've never had a problem with the old system, so I keep using it. I've evaluated the new systems. I don't like them as much, but Wolf refuses to accommodate me and keep the old system. So we're using our equipment we've had now for 18 years, but it works great. We just keep getting it serviced, maintained, and fixed as needed. Congratulations. I'm very happy for you. It makes me happy to hear a discitis debridement. That's great. I've done that. I think maybe you've seen one of my surgeries. I did a lumbar discitis debridement about 2 months ago, 3 months ago now at L5S1 and O45. So some of the things that I like to do when I'm treating an infection of the disc or possible infection, number one, you want to get a culture, obviously. You want to grab some of that disc material that's infected, send it off to the lab. So you don't want to give preoperative antibiotics, IV. You want to make sure you don't give preoperative antibiotics and just go in and harvest some of that tissue. Once you've harvested the tissue, you give IV antibiotics in the operating room, whatever it is you think the infection is due to, usually gram-positive. So you give some type of a, third-generation cephalosporin, and then the other thing I do is I will irrigate with bacitracin diluted, not full strength. Do not use full strength bacitracin. You will cause discitis yourself by putting it in there. So I use a dilute 1 in 10 bacitracin in sterile saline, and that will kill most bacteria, fungus, virus, anything that it could be. Usually it's bacterial, fungal, or protozoa, I guess, or TB. And then the last thing I do is I will put some vancomycin powder in the disc as I'm finished. That's because in America, most of our spine infection, discitis, osteomyelitis, is going to be gram-positive. So vancomycin is typically very effective. Without knowing the culture sensitivity, vancomycin is a good choice. You may want to choose something else depending on your population. But placing intradiscal antibiotics is a great idea. So anyway, kudos to you.
We have about 2 more questions. This next one is coming from Darren on Facebook.
Hi, Darren, on Facebook. Welcome.
Asking, other than referred pain, what causes additional disc pain?
I'm not sure. I understand your question. I'm trying to understand it. Other than referred pain, what causes additional disc pain? I don't understand the question. Disc pain, go back and watch the videos. Disc pain comes from the disc. It is called discogenic pain. It is pain emanating from the disc. The disc itself is hurting. And the specific part of the disc that hurts is the posterior annular tear, not the anterior, not the lateral, posterior in the back of the disc, the tear in the back of the disc. That's where the pain comes from.
And then lastly, from Faisal, once more on Facebook, asking, Doctor, I've always wanted to know if you have a pinched nerve or spinal cord without symptoms, or little is it right to operate and decompress the nerves? Without treatment, can the nerves eventually snap like an electrical cable?
Faisal, great question again. So Faisal is asking, if you have a pinched nerve on your MRI, but you have no symptoms and no exam findings of weakness, numbness, then, and you don't treat it, will it eventually pinch and snap. No, it will never pinch and snap, but the herniation can get worse, bigger, and pinch it more and crush the nerve. Nerves don't snap. They have an outer covering, like a sausage covering, a coating that's very thick. It's called the epineurium. And then they have a perineurium and an endoneurium. These are thick connective tissue. It's like a sheath. As a matter of fact, it's that sheath that's the reason why RFA doesn't work. And Duke plasma rhizotomy does work, because I cut that sheath, that epineurium sheath, with my wand, and that's why the nerves never go back, the pain nerves, okay? So, could the nerves get pinched severely with more herniation, more pressure? Absolutely. Could you start losing function, such as weakness? Yes. Will the nerves grow back after you do the surgery? Yes, they should, as long as you get it done soon enough.
We do have one more question that just came up from Rusty on Facebook,
Hello, Rusty on Facebook. Welcome.
asking, I have a T8-T9 disc that you will be fixing soon, and I will also have a facet joint at L5S1 that's causing me a lot of pain. I have degenerative disc disease and osteoarthritis. What can I do to keep the other disc from going bad?
Hey, Rusty. So I hear your question. We're going to fix your thoracic disc T89 and the facet at 5-1. Great. What can you do to prevent the other disc from going bad? I'll be honest with you. Don't get a traumatic injury to your spine. Like, don't get in a car wreck. I mean, to be honest with you, it's kind of hard to avoid it, right? Because nobody wants an accident. Nobody expects an accident. Accidents happen. So you can't live your life in fear. But here's what you can do. This is the important part. See, when human beings suffer every day, life is miserable. And people search for answers. You found the answer. We're here. We can fix it. We're right here for you. Okay? So the good news is, if you do injure more discs, come to Duke Spine. But don't live your life in fear of injuring discs. Okay? You have a partner. We're here to help you. People like you get out of pain. That's what we do. So the good news is you don't have to give up hope. You can keep your hope. We are here. We can fix your problem. The bad news is nobody knows when an accident's going to happen to your spine. But, be smart. And my sister was just on the ski slope 2 days ago up in Utah with her husband and a snowboarder. And I have nothing against snowboarders, because I am a snowboarder and I have been for 40 years. Snowboarder came across the mountain and hit her and basically knocked her out. And so did she expect it? No. But she's skiing, right? So anybody that skis knows there can be an accident. It's in the back of our head. For everybody that skis or snowboards, we all know you can have an accident. You never know when it's going to happen. Somebody coming down the hill, they don't see you, you don't see them, they lost control, and you guys collide. So, I mean, I'm not going to tell you not to do activities you enjoy just because you're afraid of having an accident. I wouldn't do that. Go out, enjoy life, live life to its fullest, and if you have a problem, come to Duke Spine, let us fix it.
That's it for questions.
All right, it's been great. I'm so happy you guys, came in at the last minute with tons of questions. I like answering them. Our next patient comes from Canada again, and this patient has really bad herniated disc at 3-4-4-5-5-1, and they're pinching the nerves, causing weakness in his legs. So he can't work anymore. He's constantly taking 2 steps and then having to stop and sit down. So he's here to get fixed with our laser surgery. Thank you. So join us in 15 minutes. Go to the bathroom, take a break,